Good morning, everyone, and welcome to today's webinar on oocyte preservation, social and medical indications, featuring Dr. David Ryley from Boston IVF's Downtown Boston Center. Before we get started, I would like to go over a few quick items about today's event. First, all physicians in attendance will receive an AMA PRA Category 1 credit, and all other providers will receive a certificate of completion for 1 contact hour credit. Additionally, we encourage you to submit your questions to Dr. David Ryley using the question section of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer session at the end of today's presentation. Now, I would like to introduce you to today's speaker. Dr. David Ryley is a board-certified reproductive endocrinologist at Boston IVF and a clinical instructor in the Department of Obstetrics and Gynecology and Reproductive Biology at Harvard Medical School, where he teaches the next generation of fertility experts and performs research to improve future care. Dr. Ryley completed his medical degree and residency at Tufts University School of Medicine and his fellowship in reproductive endocrinology and infertility at Harvard Medical School, Beth Israel Deaconess Medical Center. His clinical interests include fertility preservation, egg freezing for survivors of cancer, as well as those who are undergoing treatment for cancer. He is a medical advisory board member of Fertile Hope, a national nonprofit organization that provides comprehensive support to cancer patients whose medical treatments put their fertility at risk, and is an active member of the International Society of Fertility Preservation. As a gay man, he also has a special interest in providing family building options to LGBTQ+ community. Dr. Ryley specializes in all aspects of fertility care. Now I'm going to pass it over to Dr. David Ryley.
Good afternoon, everybody. I was about to say good morning because I stayed up way too late to watch the Red Sox win today. Melissa, thank you so much for that introduction. We're going to be talking about egg freezing, a subject that I'm sure all of you are hearing a lot about, probably too often from our patients and perhaps social media, as opposed to medical conversations, the one that is being discussed today and brought to light today. And I hope this will allow us to learn more about egg freezing, its success, the parameters that define that success, and how we can best educate our patients. I have no disclosures to give today. So egg freezing, what we're going to talk about today is the history of egg freezing, how it's improved over time due to our enhanced technologies, something called vitrification as opposed to the former technique, which was known as the slow freeze. Importantly, you're going to hear me discuss over and over again how the impact of age plays such a huge role on whether or not a projected egg freeze cycle will be successful, looking at some of the risks, some of the concerns, and how we can propose the best applications for egg freezing now that this technology is no longer considered experimental, whether they are medical or whether they are social. So the freezing of cells and tissues is basically the process by which you subject these tissues to sub-zero temperatures. You will cease biologic activity and you are preserving these tissues for future use. Over the centuries, exposure to cold was thought to be medicinal. And in the mid-20th century, our initial efforts to freeze tissues was somewhat ineffective, and that's basically due to the fact that, especially when it comes to the egg, these tissues were prone to ice formation, and that ice formation rendered this process ineffective, basically due to the severe osmolarity changes that occur when you subject tissues to this type of cold. Finally, in the mid-20th century, we were able to devise the use of what we call chemical osmoprotectants to decrease the severe osmolarity changes that engendered this type of ice formation within these tissues. And as a result, with the use of these technologies, the first human birth from frozen sperm was identified and occurred, and it was published. And by the time we got to the 1970s, we got better at this by using these, quote, cryoprotectants, unquote, to minimize the cellular damage associated with this process. In the 1970s, we were able to program what's called the slow freeze technique that allowed somewhat of a sufficient amount of cellular dehydration, somewhat minimizing intracellular ice formation. And as a result, the first human birth from a frozen embryo was reported. And in 1986, because of our improvements, the first human birth from the use of a frozen egg, the topic we're discussing today, was reported. That was a long time ago, but we really haven't started talking about it until now because it was a very inefficient process. Well, that inefficiency was cured in the early 2000s when we developed what's called the vitrification technology. And this is a rapid freeze technique in which you're using high concentrations of these osmoprotectants. You have an ultra rapid plunge freezing these tissues into liquid nitrogen. And we now use this for our embryos, and as you see, eggs and ovarian tissue. And that has exploded this science into a better technical result and usefulness for our patients. So vitrification, again, results in this rapid freeze technology. It minimizes ice crystal formation. And what you see on the right is the classic ground glass appearance of an egg that's been previously frozen and then thawed and looks very healthy. It's challenging. It's challenging to freeze an egg purely because it is replete with water. It's the largest cell in the human body, and all the checkpoints in that egg that control the process of fertilization might be impacted by freezing. The zona pellucida, which is the outer layer, that glycoprotein layer that's very sensitive to freezing. The cortical granules, those subcellular components that are going to release the enzymes that help control normal fertilization. And most importantly, the impact of freezing on the meiotic spindle on which chromosomes are known to align. So why is that important? Well, we all know that our eggs start out as diploid cells. They have 46 chromosomes. And for those eggs to eventually fertilize normally, they have to initiate the process of meiosis, which, as you know, the first part of that reduction division is releasing a polar body. And that occurs at the time of the LH surge. And at the time of fertilization, the second polar body is released. So that reduction division has taken that diploid cell, the egg, to a haploid cell that can fertilize normally. And it's going to require that those chromosomes align normally on the meiotic spindle. And concerns were, especially when we started this process, that the spindle might be impacted. In fact, here you see data published in 2009 in which eggs were frozen and then thawed. And the staining you see here is staining of the tubulin protein that makes up the meiotic spindle, as well as the red, which is looking at the chromosomes. And as you can see from frame B through D, there's this disordered, abnormal array of chromosomes that were felt to indicate that egg freezing might be detrimental to normal chromosomal alignment. However, with the enhanced use of vitrification, the new technology, we now have improved egg survival compared to the older technique, and meiotic spindle recovery upon thaw is faster and normal. So again, it's vitrification that has allowed us to improve this process so that even though the first baby born from a frozen thawed egg was 1986, it's now a much more successful process. Plus, we're using intracytoplasmic sperm injection, which is commonly used in IVF. The number one reason we use intracytoplasmic sperm injection for infertile women is that the male partner has low sperm counts, the number one reason we do IVF. And the way you overcome that male factor infertility is intracytoplasmic sperm injection. And here, when you thaw eggs that are mature, you're going to directly inject the sperm into that thawed egg. By so doing, you're overcoming the, quote, hardening, unquote, of the zona pellucida and facilitating normal fertilization. So the combination of the vitrification and the judicious use of the ICSI has been very successful. In fact, way back in 2008, we published an abstract that was presented to the American Society of Reproductive Medicine, and we took eggs from 8 anonymous egg donors. So individuals that donating the eggs for intended parents whose infertility was related to a diminished ovarian reserve. 140 mature eggs were frozen. They had an excellent survival rate, subsequent excellent fertilization rate, and the embryos so derived were monitored to the cleavage stage, at which time they were tested for chromosomal status through a technique that's no longer used, and then those embryos were grown to day 5 of their development. 43.5% of them had a normal array of chromosomes, and subsequent transfer of these embryos derived from originally frozen thawed eggs, clinical pregnancy rates were excellent. That was part of the emerging data showing the efficacy of vitrification and intracytoplasmic sperm injection. But the landmark study, a randomized controlled trial, was presented in 2010, published in Human Reproduction. This is a great study. They took 600 infertile women who were candidates for receiving egg donation due to their diminished ovarian reserve. And the subjects were randomized to receive eggs from donors that were previously frozen, and the controls did routine fresh donor oocyte IVF. So embryos are being created from either fresh eggs, the standard technique, or frozen eggs, the non-standard or subject technique. And I don't know how well these slides show, but the clinical pregnancy rate amongst those intended parents who used the frozen eggs versus the fresh eggs were no different. Similarly, the ongoing pregnancy rate between the intended parents using the frozen eggs versus the fresh was no different. And what the authors were able to say was they could not demonstrate the superiority of using fresh eggs compared to the egg bank that had been created with the frozen donor eggs. So that was very reassuring, very interesting, and certainly in this young cohort, meaning young egg donors, it appeared to be successful and consistent with the standard approach of using fresh eggs. Now, admittedly, there's limitations to this data analysis. There's a small number of similar randomized controlled trials, so how well can we generalize the data? And like any new technology, it's prone to a publication bias. And as you're going to hear me say over and over again, the best data is amongst a younger cohort of individuals who are freezing their eggs, just like in this study in which the women donating the eggs were egg donors, meaning young and in their 20s. So as with fresh eggs IVF cycles, egg donation or egg freezing amongst women of a more advanced age is less successful, and that's a key point. Looking at the impact of age, here's a study published in Human Reproduction in 2012. It was a multi-center trial amongst women with infertility. So this is not necessarily the cohort we're talking about, but in these individuals undergoing IVF, instead of freezing surplus embryos, they froze surplus eggs. And if they needed to use those surplus eggs, thaw them and fertilize them to get pregnant, as one might expect, there was an inverse correlation between the maternal age at the time those eggs were created and the delivery rate from the thaw and fertilization of those eggs. And they designed a predictive model, and they looked at the probability of achieving delivery when these extra eggs were thawed and fertilized when there was less than 8 available. And clearly, when stratified by age, significant differences for women under the age of 38 compared to those over 38, looking at the live birth rates when the eggs were thawed. And you'll hear this theme over and over again. that eggs do best when they're frozen at a younger age. And so why is that? Well, we have to refresh our own memories and teach our patients about the impact of age on what we call the ovarian reserve, which reflects both the quantity and the quality of eggs that are available. So as we all know, the female primordial germ cell mass is at its peak when that female is a fetus in the mid-trimester of her mother's pregnancy. And there's this mitotic proliferation that creates this large mass of 60 to 20 million primordial germ cells. But it's at that time that an apoptotic cascade, meaning a programmed cell death, overcomes the continued mitotic proliferation. So that at the time of birth, there's a finite supply of 1 to 2 million primordial germ cells. That apoptotic cascade continues, but there's no further mitotic proliferation of these cells. So at puberty, when there's a maturation of the hypothalamic pituitary gonadal axis, meaning ovulation is going to start, that finite supply is about 300,000. And that continued loss of eggs will occur so that menopause will eventually be reached. But with these loss of eggs, it's both a quantitative and qualitative issue that the older eggs will be of less health, so to speak, and less likely to be candidates for successful egg freezing. You can see these trends in the diagram that I show you on the left, or the graph you see on the left, where there's this exponential decline in egg numbers that occurs for women in their mid-30s and older, confirmed by histologic specimens showing the follicular activity in ovarian tissue as women get older. The classic study looking at fertility and the impact of age was published in 1957 on a population called the Hutterites. And this was a religious group that congregated in the Midwest, and under religious and paternalistic dictates, they were required to have unprotected intercourse to build their families until pregnancy was no longer possible. And this was a classic study looking at fertility, and therefore addresses age. And basically what that study showed, that by the time of age 40, 1/3 of these women were infertile. They were unable to achieve a pregnancy that led to a live birth. 87% were infertile by the age of 45, and the average age of the last birth was 40.9 years. That fertility data applies to what we're talking about, the qualitative and quantitative decline in our ovarian reserve. And that study, which still serves as the classic study, parallels very well multiple studies that have shown the same data. In fact, here in these studies, when you see how it's compiled and the decrease in fertility, it parallels almost exactly the previous graph I was showing on the exponential decline in egg numbers that one sees from the mid-30s into the 40s. And when we're talking about infertility, we're not talking just about the ability to conceive. We're talking about miscarriage rates. And so as we get older, increased rates of miscarriage, so that if you include both clinically recognized and unrecognized conceptions, miscarriage rates for women over age 40 are significantly high. And why is that? Well, the eggs have a much harder time going through that process of meiosis I was referencing earlier. So once these eggs divide, they have to figure out how to go through that reduction division. And due to the oxidative stress of aging, the separation of homologous chromosomes becomes more problematic due to, on a cellular level, what's called the anaphase lag, so that more gametes will have an abnormal number of chromosomes, and therefore more resulting embryos will be abnormal. They will either therefore not implant, or if they do implant, they will result in miscarriage. On a more concrete level, you can see that as published in this study in 2003, where eggs were retrieved from women who underwent controlled ovarian hyperstimulation. Those eggs were retrieved and they underwent a specialized staining technique looking at the chromosomal number. So a haploid egg, a healthy metaphase 2 egg, should have 22 autosomes and 1 sex chromosome. And this black line shows the percent of eggs over the x-axis, which is referencing age, increased number of chromosomally abnormal or percentages of chromosomally abnormal eggs approaching 100% in the early 40s. But again, that exponential increase we see in the mid to late 30s. So those are some of the concerns. The older we get, the less useful those frozen eggs will be. Additionally, there's concerns with birth outcomes. So this is data that was presented by Nicole Noyes from NYU in 2009, and she did an extensive literature search comparing birth outcomes of babies born from previously frozen thawed eggs to US national statistics. And encouragingly, what this slide is showing you, that there was no difference in birth outcomes. The risk of birth defects was the same, and that was very encouraging. Admittedly, short-term data is reassuring, and we don't have long-term data on developmental outcomes. And as I have said already, much of the data is limited to younger individuals as opposed to women of a more advanced reproductive age. But due to the fact that birth outcomes looked good, and due to the fact that vitrification made this process so increasingly successful, it was as of 2012 that the American Society of Reproductive Medicine and the Society of Assisted Reproductive Technologies deemed egg freezing no longer to be considered experimental. And since that time, this science has really taken off. And it's since that time why you've heard so much more about it. But even though that was 2012 and we're now in 2021, the American Society of Reproductive Medicine still is searching for more evidence-based data. And with their updated literature search, which has been very extensive, they claim that the evidence to predict a live birth after planned oocyte cryopreservation is still limited. Meaning, if a patient presents to my office and she wants to freeze her eggs, I need to caution her about the imprecision of this data. But much like you've heard, the best data is for women who do this at a younger age. What does the Boston IVF experience show? Well, we just published this article. The lead author is Angela Young, our graduating third-year fellow who's now down in New York, spectacular young physician. And we looked at clinical outcomes over our previous decade of experience of planned egg freezing in patients freezing these eggs for social indications, not medical indications. So what do we see? Well, 7.4% of the patients have returned to use these frozen eggs. And that's another important point. We need more data. Most of these women who are freezing their eggs, perhaps when they're having their first child, are still fertile. But as they get older and build their family, and they're found that they need an egg donor, and therefore they need to use their previously frozen eggs, that's the data we need to accumulate, and much of that has yet to occur. Encouragingly, the clinical pregnancy rate for embryo transferred from these eggs that were previously frozen and thawed was 47.5%. And of note, we have not had a live birth from any egg frozen in which the individual was over the 40 years, but the data set is so small, it's hard to extrapolate the significance of that data. So how can we use this? We now have egg freezing no longer being considered non-experimental. Well, one simple application that we routinely do is we're making egg donation easier. So for individuals who, due to for whatever medical or a reason related to age, need an egg donor, the old technique is where you would take that egg donor, and she would be undergoing IVF, and you would program her IVF cycle with hormonal stimulation, so to speak, of the recipient's uterus. So you're basically aligning and synchronizing the recipient with the donor. Somewhat inconvenient in that donor had to be ready, and you certainly had to rely on her compliance in taking the medication appropriately. Our newer technique is a lot easier. The eggs are already frozen. It allows so much more flexibility for both the donor and the intended parents, and you avoid all those issues that are often related to the donor's compliance because it's already been done. Her IVF has already been done. In fact, Boston IVF, along with a lot of the leading infertility centers in this country, belong to Donor Egg Bank USA, which basically means my patients who need an egg donor are using eggs that are previously frozen, and we can get those eggs, retrieve them from many centers belonging to this group. So one application is the simplification of egg donation through freezing previous eggs retrieved from younger donor individuals. How does this process work? So egg freezing is just like what women go through when they do IVF. So they undergo controlled ovarian hyperstimulation. So as we all know, every month there's a group of follicles that are metabolically active. They have developed through genetic mechanisms over the previous 85 days. And then within that menstrual cycle, those that are metabolically active are potentially deemed to ovulate. So a woman's FSH is going to allow one to be released, one to ovulate out of the group that's ready, and then the rest will have a programmed cell death. So when we are instituting controlled ovarian hyperstimulation, we're just supplementing the FSH, and we're rescuing the eggs that are otherwise going to be lost from being lost. So there's a common misperception in the real world that when eggs are being retrieved, either for infertility, such as IVF, or fertility preservation, that we're exacerbating any potential future infertility. We are not. We are saving the eggs that are being lost in that month. This is a schematic representation of how that is done. Basically, it's done in an outpatient setting. The patient is under conscious sedation with propofol and fentanyl. She's placed in stirrups, and during this 10-minute procedure, a probe is placed in the vagina with a 17-gauge needle that is directly guided into the follicles from which the eggs are drained. It's a simple setup. This is the table that's next to the surgeon. And here you see the tubes that are going to be used to collect the fluid being aspirated from that 17-gauge needle that I was referencing. And this is the ultrasound probe, the attached needle guide. Here's the ultrasound right next to the embryology lab, which is collecting the fluid in those tubes. So the surgeon is sitting there. There's the hyperstimulated ovary. The follicles are drained of their fluid, and the embryologist will sift out from that fluid the eggs that are so retrieved. Now that it's not experimental, in addition to simplifying the use of eggs for donation, what are the other proposed applications? Certainly fertility preservation for patients who might be facing iatrogenic menopause, or at least an acceleration of the diminished ovarian reserve due to their exposure to gonadotoxic therapies such as chemotherapy or radiation therapy, both of which might be used for cancer, obviously, in certain benign conditions. And then there's the social indication for those women for whatever personal, professional, or medical reason are concerned about needing to defer their childbearing. And increasingly, and fortunately, we are able to serve our transgender and non-binary community. We have many transgendered men who might interrupt their hormonal therapy, or before they complete their transition, whether their ovaries are going to be removed or not, those men would like to have a genetic child in the future, and these men can undergo the controlled ovarian hyperstimulation necessary to retrieve eggs that can be frozen. And in the future can be fertilized with a sperm donor, with sperm from a partner, that transgendered male may keep his uterus intact and use these embryos to carry a child. There's many ways we can serve this population, and I can honestly say it's incredibly rewarding to be able to do so. Initially, when I was trying to preserve fertility for patients facing gonadotoxic therapies, particularly for cancer, if a sperm source was not available, they were not coming in with a partner, the only option we had was embryo freezing. And therefore a sperm source was necessary, and that was very uncomfortable and difficult for them to do. But now we can do this without needing a partner, and also avoiding some of the legal and ethical issues that some patients have with the disposition of surplus embryos. It was in 2005, updated in 2012, and most recently in 2019, that the American Society of Reproductive Medicine published their ethics committee report on how do we manage these patients who are facing gonadotoxic treatments. And it paralleled nicely with similar suggestions from the American Society of Clinical Oncology. And basically, both societies reiterated that physicians, oncologists, should inform their patients about options for fertility preservation prior to treatment, and that the only established, meaning not requiring any type of IRB oversight for fertility preservation, sperm freezing in men, embryo, and as of 2012, egg freezing in women, and as recently as 2019, ovarian tissue freezing, which is a topic for another lecture. And why is this so important? Well, thanks to our oncology colleagues, their judicious use of therapies such as chemotherapy and radiation therapy, and their increased surveillance, our patients with cancer are surviving, and those patients are focusing on reproductive capabilities. In 2018, more than 800,000 new cases of cancer were diagnosed among women, and among premenopausal women, women with reproductive potential, 11.1% have a cancer diagnosis potentially placed upon them. But the death rates from these cancer have markedly improved. Most of that with breast cancer, but the other cancers known to impact women of reproductive age have markedly improved survival rates when you compare it to back into the 1970s and 80s when I was a resident, for instance. And that improvement allows us to let them preserve their fertility prior to undergoing these treatments, which we know are detrimental to both the male and female reproduction due to the impact mostly on the gonads. And this allows us to pose a rather provocative question. Perhaps chemotherapy is the most common known cause of gonadal failure. Look at it this way: 2.2% of women of reproductive age will face a cancer diagnosis. About half of those might need to undergo gonadotoxic therapies. We can provide options for these women before they face those therapies, as long as their oncologists are comfortable with the timeline and type of treatment that we're offering. But it's not just chemotherapy. It's radiation therapy that's directed towards the pelvis. And from our understanding of the natural decline in the primordial germ cell mass and the dose of radiation that a patient is exposed to, you can look at the y-axis, the dose, and the age, and you can decipher between what is the chances 50 to 100% that this woman so exposed to this radiation at this age will face ovarian failure. And we should be able to use those projections and strategize with our oncology colleagues which patients would be best served with fertility preservation. But there's a drawback. It requires a stimulated cycle, and certainly that might not be a timeline, that delay that an oncologist finds acceptable. And we can't necessarily say what is the impact resulting from this process of supraphysiologic levels of estrogen, for instance, on a hormonal sensitive malignancy such as an ER positive breast cancer. Thankfully, we can use a selective estrogen receptor modulator like tamoxifen or an aromatase inhibitor like letrozole, mitigating the impact of this estrogen on an estrogen receptor positive tumor. And the data has shown us, followed in a longitudinal fashion, that women who undergo these treatments are not impacting the course, the prognosis, or the treatment of their cancer. And obviously, the only type of cancer patient who would be able to respond to these treatments are those who have a mature pituitary gonadal, hypothalamic pituitary gonadal axis. And there's other medical indications. You may have a BRCA patient who, although she does not have a cancer diagnosis, will someday face a prophylactic BSO. And typically that's recommended between the ages of 35 to 40 or when childbearing is complete, whichever comes first. Turner syndrome, those patients who have a mosaic Turner syndrome genotype may have enough ovarian activity that you can freeze eggs for those patients. Because of their privation of the full set of X chromosomes, they will have an accelerated time to menopause, and if they are diagnosed early enough, you might be able to freeze their eggs. Similarly, we see this with fragile X mutations. And in my world, it is not uncommon for a patient at the day of her egg retrieval to have suddenly a lack of a source of sperm due to whatever logistic issues occur with the male partner or the donor sperm at that time, and you might need to do an emergency egg freeze. What about social indications? This is a provocative topic. So what you're looking at is a publication in 2014 from Bloomberg Business Week. And basically it was freeze your eggs, this is the title, freeze your career. And a quote directly from that article said, imagine a world in which life is not dictated by a biological clock. This is how this is being viewed by the lay public. Well, a statement by the American Society of Reproductive Medicine as recently as 2021 says their quote is an extremely limited evidence to predict the likelihood of live birth in women who undergo a planned egg freeze. So in other words, we're waiting for evidence-based data. And as you heard me say before, we need to build up that data set. So there's concerns expressed, appropriately so, regarding efficacy, cost effectiveness, the emotional risk, and we are cautioned not to market this and infer somewhat of a false hope. So the American Society of Reproductive Medicine does not necessarily recommend elective egg freezing. So what does ACOG say? Well, they recommend that patients who will be undergoing iatrogenic injuries to their gonads, such as those who are receiving chemotherapy, that this is an appropriate treatment that should be undertaken. But, quote, they feel there's insufficient data, just like ASRM, to necessarily recommend this for the sole purpose of circumventing reproductive aging in healthy women. One of the concerns here is age. The patient does not have the opportunity to get pregnant for whatever personal or professional reason. Age is gonatotoxic, just like chemotherapy and those treatments. And I think they're walking a fine line here. But the point is, ACOG also does not necessarily recommend elective egg freezing. And I think our professional organizations, to a certain extent, are swimming upstream against a very strong tide. I agree, we need to have more evidence-based data. For sure, we need more evidence-based data, but we can't ignore the fact that our socio-demographic changes and the availability of this no longer considered experimental technology is driving this need to try to preserve fertility. So how does the lay public look at it? Well, this is a book that was published and it was a bestseller in the New York Times in 2013, 1 year after egg freezing was no longer considered experimental. And the author, Sarah Elizabeth Richards, defined herself and the other women who are profiled in this book as the clock tickers. A woman who wanted to take advantage of her egg freezing before she lost the chance to, quote, become a mother. I don't like that wording because there's many ways to become a mother, but I'm just directly quoting from this book. And she felt that the lack of availability of egg freezing technologies, and just as importantly, the lack of insurance coverage, was being applied in a rather sexist way, that women were being, quote, judged, unquote, for needing to do this. And I wouldn't disagree. I do think it's rather sexist. And she felt that women who were doing this to prepare themselves for becoming a mom when they were more financially sound and they had found potentially the right partner, that they should be celebrated for so doing. And that is how the lay press, the lay public, is looking at this issue. So let's look at data that's been collected. Here we see data published in 2013 out of NYU, and this was before egg freezing was non-experimental. So this required IRB oversight. They looked at 478 women who were deferring their childbearing and completed at least one egg freeze treatment cycle. And they surveyed these women looking at their motivations, their desires, etc. 50% of the women were referred to do this by a friend, about a quarter by their OBGYNs, and often through social media or non-medical sources. 88% of these women did this because they yet to have found a partner with whom they would want to have a child. 60% felt that based on what appeared to be their deferred building of a family, they're likely going to need to use these eggs, or at least very likely to use these eggs. But let's look at it a little more deeply. They saw this as a backup plan, and 53% found it to be empowering. But what concerns me is the 36% who felt it was anxiety provoking. I think we need to take that into account. These are elective therapies. We don't have to do these treatments, and we have to recognize the emotional response that these patients have. We have to support them, but you certainly don't want to coerce them into doing something that they might think they have to do, but they might not have to do it. And that's an important point. You really have to respect the emotions associated with this process. And when these patients present to me, whether it's an infertility diagnosis or desire to preserve fertility, they have to be candidates. They're not automatically candidates. In other words, they have to have a normal ovarian reserve. And that's measured routinely in the early follicular phase of the cycle, at which time they should have normal gonadotropin levels, a low estrogen level, and therefore I can use this data to prognosticate whether they are candidates. A patient can come in at any age and she can have an abnormal ovarian reserve, and I therefore know she will not respond well to my treatment, and therefore I cannot offer it. And that's often a very difficult conversation. Other ovarian reserve tests include a Clomid challenge test, in which a patient has gonadotropin measures done before she takes Clomid for 5 days in the follicular phase of her cycle. At the end of those 5 days, an antral follicle count by ultrasound, and increasingly and importantly, serum AMH levels. AMH is basically a growth factor. It is secreted by the granulosa cells of the growing follicles. It's a direct measure of the ovarian reserve. It's more independent of the pituitary, meaning it can essentially be obtained and evaluated at any point in the menstrual cycle. And this is really important for patients who are presenting for fertility preservation prior to receiving chemotherapy, in which I don't have time to time things with the menstrual cycle. But it's important when you're looking at these ovarian reserve measures, all I'm looking at is, can I offer this therapy? It does not at all imply an ability or inability to conceive. That's not what it's doing. It's just allowing me to assess this patient's candidacy for treatments in which I'm going to be using gonadotropins. Focusing a little bit more on the AMH, as I said, it's directly secreted from the granulosa cells. It's more independent of the menstrual cycle, but there is some artificial lowering of it, and therefore it might be somewhat harder to evaluate in women who have a more extreme weight. women with idiopathic hypothalamic hypogonadism, prolonged OCP use, or those who have been recently exposed to GnRH agonist therapy. Here you see data from David Seifer in 2011 showing the expected decline in the AMH that occurs with increasing age, once again reinforcing the point that the older the patient, the lower the AMH, the lower the likely good response to treatments that can be offered. So when a patient does come in and she's requesting these therapies, we assess the ovarian reserve, and here's a classic normal ovarian reserve. A good early follicular phase FSH level, relatively low estrogen level, a normal AMH, which you can project to give you how many eggs are going to be retrieved compared to a woman of her age. If these tests are not normal, I cannot offer these treatments, and the patient's opportunities to do this is lost. And again, too many of these patients, when they see me, even though the discussion starts as talking about fertility preservation, they interpret these tests as a reflection of their inherent fertility, which they are not. This issue was addressed in JAMA in 2017. They looked at 750 women of reproductive age who had no history of infertility and who were trying to conceive, and they had measures of the ovarian reserve done at the appropriate times, and then they were followed at time points of 6 and 12 months looking at pregnancy rates. And the bottom line is, for instance, with AMH, women with a low AMH had actually in this study a higher pregnancy rate over 12 cycles of observation than women with a lower AMH. Now, one of the flaws of this study, which is often the case when you're looking at data from non-OBGYN sources like JAMA, they didn't follow the pregnancies to miscarriage rates. Yet there's no data that shows AMH levels are correlated with miscarriage, and this is just an important point to make. These tests are done to assess response to treatment, not to inherent fertility. So what can I tell a patient? Well, this is data that was collected in 2016, and updated tests show similar types of results. So if a patient presents to me to preserve her fertility, irrespective of the indication, if she's in this age group and she freezes 20 eggs, if she's ever diagnosed with infertility, which might not be the case, and within the context of that evaluation, she's told that she has a diminished ovarian reserve and therefore needs an egg donor, that's what she's doing. She's freezing her eggs to serve to be her own potential future egg donor. If you thawed 20 of those eggs, 95% would survive the thaw. You would inject them with sperm, 70% would fertilize, and of those, 50% would make it to day 5 of their development when they're blastocysts. And you would create a bank of blastocysts from the original lot of frozen thawed eggs. The chance that that bank of blastocysts would give you a live birth is 80 to 90%. A second live birth, 50%. That's very encouraging, but again, it's not based on a randomized controlled trial, and it's prone to publication bias. And again, not enough women have come back to use their eggs, but that's the kind of data we're seeing over and over again. When you get to the more advanced age groups, to get this number of eggs and yield similar results requires multiple cycles, and it's much harder to achieve success, especially when this is not covered typically by insurance when it's being done for non-medical reasons. So that same woman who was profiled in that Bloomberg Business Week article was the subject of an article in 2018 in the Washington Post. And the title of that article in the Post was "The Struggle to Conceive with Frozen Eggs." So this woman worked for high-tech marketing companies. She was understandably dedicated to her career, and due to her concerns to defer her childbearing, she froze her eggs in her late 30s. I believe she was 38. By the time she reached the age of 45, she had yet to meet a partner, but she wanted to conceive a child, and she thawed the 11 eggs that were frozen. One normal embryo resulted, and a live birth was not achieved. So the data when she did this probably didn't include some of the data I've shown you, how we need to freeze a lot of eggs for women in that age group to be successful. But look at the responses, the quotes that this woman gave when it was unsuccessful. Quote, "The worst day of my life. She was sad. She was ashamed. What did I do wrong?" She did nothing wrong. But egg freezing is a process that women need to be emotionally, physically, and financially prepared for. And it has to be done in a way that you can maximize success, you can't provide a guarantee, and hopefully mitigate circumstances like what played out here. From this same article, you see the exponential increase in egg freezing that has occurred, especially since 2012, when it was no longer considered experimental. And once again, reaffirming the earlier time to do it, the better the chance that these eggs will eventually lead to a live birth if it is necessary to thaw them, fertilize, and create those embryos. A previous article that I cited, looking at the demographics of patients who do this, concluded with the following. Egg freezing may increase a woman's or an individual's, I think it's a better term, security regarding their ability to bear their own genetic offspring, universally ranked above non-biologic procreative choices, non-biologic meaning donor egg. I also think it behooves us as reproductive endocrinologists to embrace donor egg, to tell patients it does give them the ability to carry and deliver a child and to have a significant biologic connection. We need to have that discussion with them, but I do recognize how important it is for individuals to have their genetic child. So that is kind of a brief overview. I hope it wasn't too quick on egg freezing, the social and medical indications, and I'd be more than happy to entertain any questions that anyone might have. Thank you for listening today.
Thank you, Dr. Ryley. That was great. We're now going to begin answering the questions submitted during today's presentation. As a reminder, you can still submit questions through the questions pane in your attendee control panel. Dr. Ryley, our first question is, what age do you recommend speaking to a patient about egg freezing if they are not ready to conceive, but they know they want to have children?
Personally, I think it's a tough conversation because you don't want to coerce them, but I don't think it's unreasonable when a woman is in that 30-year-old age cohort and you can tell from whatever social reason she indicates to her generalist or primary care physician that she doesn't see having a child on the near horizon, that she at least be educated about this process. And I think age 30 would be good. I think doing it in the 20s is somewhat premature.
Great, thank you. Is ICSI required for vitrification?
Yes.
Great. Is it advisable for a patient to put off radiation or chemotherapy a month or so if they want to freeze their eggs?
Only if the oncologist says it's okay. So whenever I see a patient for an oncologic indication, the first thing I do is determine where she is in her menstrual cycle, looking at her ovarian reserve, and I design a timeline that is going to be required, and I immediately send that to her onc team. And they either say yay or nay. They drive the boat. It's their job, and if they're against it, it won't be done.
Great, and I think that is our last question. Thank you everyone and thank you Dr. Ryley for attending today's webinar on oocyte cryopreservation, social and medical indications. If you have any other questions, please contact myself, Alyssa Cooper, ecooper@bostonivf.com. You can also try me on my cell phone, 978-302-2958, and I can help relay some of these messages to Dr. Ryley. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate it if you could complete the survey and provide your feedback to help with future educational webinars. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. On behalf of Boston IVF and Dr. Ryley, thank you for joining us today and have a great rest of your day. And go Red Sox.
Thank you, everybody.
Thank you, Dr. Ryley.
See ya.